hoping to talk to you guys about pediatric respiratory failure. I did pediatric residency, then a pediatric cardiology fellowship, and I'm now in my final year of pediatric critical care training. So a lot of training, and this is the typical path, as I'm sure you guys kind of know, but I've found kind of a loophole where you just kind of go through fellowship over and over and over again. In that time, I've gotten a lot of experience, a lot of wise words, a lot of education. I think probably one of the most notable things that I've learned was an esteemed physician that once told me, you know how everything works, but you can't actually do anything to fix it. And that was from my loving and supporting wife, Dr. Charlene Johnson. That was while I was a pediatric cardiology fellow. It's only half true because I don't actually know how everything works, but it did kind of inspire me to be a little bit more practical in some of the skills that I haven't with taking care of children. And I think it's also kind of informed giving talks like this in terms of how to, frame it for a field that, really prides itself in kind of being practical and hands-on in terms of its abilities and training. So with that, I'm going to use that to inform some of these learning objectives. So I'm going to be talking a lot about physiology, but I'm going to try to bring it back to practical points that you can use at the bedside when taking care of a patient. So we're going to review the physiologic basis for respiratory failure in children and some of the differences between children and adults. We're going to apply those physiologic underpinnings in pediatric respiratory failure to both non-invasive forms of respiratory support, but also mechanical ventilation. And that's really where I want to kind of focus most of the talk. We're going to focus on some of the different ventilatory modes, monitoring, setting, titration, which does cover a lot of things. I'm hoping that we can kind of get through everything and also review some cases where we can work through some different scenarios. I have no financial disclosures, but this is to remind me that I am a personal disclosure and post-call. So if I don't know what I'm talking about, that's why. Setting the stage. So in terms of mechanical ventilation, particularly in children, these treatment strategies are often not supported by strong evidence. It's usually weak evidence, small single center studies, or extrapolated from larger adult trials. That doesn't mean that they're not strong opinions. A lot of people have a set way they can handle a respiratory support, but there are a lot of different ways to handle the same kind of patient. A lot of these opinions are anecdotal, institutional, but hopefully grounded in some physiologic basis. And so we're going to talk about that a little bit. I'm not as familiar with the institutional kind of practices of NYU. This is really at my own institution and my kind of experience. And so you might see different things when you're rotating through the pediatric emergency room. But this is, I think, the framework that I've kind of operated on during my training. In talking about pediatric respiratory failure, we've all heard the phrase that children are not just smaller adults. That makes sense. A lot of the kind of physiologic principles that we're going to be talking about don't operate in a linear fashion. When we're talking about compliance or airway resistance, these are not linear functions. So it wouldn't make sense that they would kind of correlate with a linear function like somatic growth. So it's not apples to apples. And we kind of have to think about it a little bit differently. And some of the things that are the physiologic reasons that children's respiratory mechanics are different, we're going to review. When it comes to pediatric respiratory mechanics, they have increased airway resistance from the nasopharynx and the distal airways, and they make up a bigger portion of the respiratory system. In neonates in particular, and small infants, they're obligate nasal breathers. So in respiratory illnesses and viral infections that have a lot of secretions or mucus plugging, that can be a big source of airway resistance in these children. And in part because of their nasopharyngeal airways, they have a larger dead space fraction, so less kind of part of their respiratory system functioning in alveolar gas exchange. And they have fewer alveolar units. The lungs kind of develop and alveoli are growing over the first 6 years of life. And so, especially in the first couple of months, there's not as much alveoli participating in gas exchange. When we take breaths, there's collateral ventilation kind of going from one alveoli to another. That's immature in infants and small children. And one of the biggest differences is that children and infants have a cartilaginous rib cage and sternum with immature ossification. What that really does is increases the compliance of the chest wall relative to the alveoli in the respiratory system and lowers the functional residual capacity as a percent of their vital capacity. Their functional residual capacity is at or below the closing capacity. This is a graph of the different respiratory volumes. This is not a review of spirometry, but just some basic terms that I'm going to be using. So tidal volume is the normal kind of tidal volume breath that you take in terms of normal respiration. The functional residual capacity, a capacity is a sum of any two volumes. So that's your residual volume plus your expiratory reserve volume. So the most you can kind of expire in terms of removing all the air that you can from your respiratory system. And then you still have some residual left over. And so that capacity is basically what's at the end of a tidal volume breath. And that really is the point where lung mechanics function most optimally. And so the respiratory system is at its more or less its baseline. There's also a term that doesn't really come up, but is the closing capacity. And this is something that you can't really measure too easily, but it's the point at which you have periods of alveolar collapse. And it's different for everybody depending on their lung compliance, their age, and different factors. But there's some point where the volumes in the air in the lungs become such that you start to have atelectasis and lung collapse, and it kind of affects your overall lung compliance, your gas exchange, your oxygenation, and your ventilation. This is a graph from a study that was done in the 1940s, like a truly horrific study where they looked at lung compliance of the chest wall and the rest of the respiratory system and the lungs all taken separately. So they removed the lungs from an animal's body and then tested different pressures and the static compliance of the respiratory system at the chest wall and the lungs. So if you look at just the chest wall, it's a very compliant system. So at high pressures or even at low pressures, you have a relatively high volume. And the natural system of the chest wall is to expand outward, whereas the lungs, it's more to contract inward. And you can see even on the right side of the graph, there's high positive pressures, but even at negative pressures, you still have some degree of lung volumes with just the chest wall. And you can think about it, if you took a big negative inspiration, imagine you didn't have lungs, like you wouldn't be able to kind of deform your chest wall because of the muscles and the cartilage and the bones that kind of keep it sturdy and together. This is the lung mechanic graph, compliance graph. And you can see that this really only operates at positive pressures. In this study, obviously, they couldn't generate a negative intrathoracic pressure. And you can see that at even low pressures, you have complete collapse. There's no volume in the lungs in and of itself. But you sum these two together and you have a respiratory system that functions optimally at both of these points. So there are periods where it stays open at high pressures and also open at low pressures. And these two forces, the chest wall and the lung parenchyma, work in opposites to keep the respiratory system at its optimal period of compliance. The respiratory system crosses zero in terms of your pressure curve. That's your functional residual capacity and that point of optimal compliance. Probably something that you guys deal with more on the adult side is having poor chest wall compliance in patients with obesity or other limitations in their chest wall. In children, it's actually the opposite. And then there's also the closing capacity that everybody operates on where they have some degree of atelectasis, if the volumes reach below that point. In children, you have the opposite problem where you have a high compliant chest wall, but with the same kind of respiratory lung. And what that does is you don't have on this, the chest wall doesn't have that kind of rigidity to resist kind of like the inward force of inspiration. And what that does is it drives the entire system downward in terms of the volumes for a given pressure. So you have a lower functional residual capacity, and at the same time, you have the same closing capacity. So for infants and small children, you are kind of operating right at the margin of atelectasis. They're kind of always existing there. And so anything that's going to change your lung compliance is going to tip you over the edge into atelectasis. That's static compliance. You can have dynamic compliance, which kind of factors in airflow and airway resistance. This is inspiration and expiration. You can see that the curves are slightly different, and that's because of the surface tension of your alveoli, which kind of changes again in relation to a number of different factors, especially in very small infants and premature infants. They don't have adequate surfactant that kind of influence their surface tension. And kind of this point of maximum compliance where the airways open up and reach a certain volume, again, is their functional residual capacity. You can see this graph actually on a ventilator, and you can get a sense of the patient's compliance and how it changes with different applications of ventilator maneuvers and application of positive pressure. You might see a graph that looks like this, where you have a period where there's increased pressure without a given volume. And that's telling you that you're at your closing capacity and that any pressure you're generating from a ventilator is solely working to open up alveoli and reach that functional residual capacity. But every time you exhale and go back to the pressure baseline, you have atelectasis and alveolar collapse. I've showed you many graphs, talked about a lot of physiology, but I always have to bring it back to start telling me, how is this relevant? Infants and children need PEEP in order to maintain their functional residual capacity. That's really what's going to be the way that you kind of optimize their respiratory mechanics. So if they're showing signs of not oxygenating or ventilating appropriately, PEEP is usually the answer. What are some of the signs of respiratory failure? We all kind of know them: tachypnea, retractions, nasal flaring. The one that I want to really highlight is grunting, which is something that you see in infants and small children, and that's expiring against a closed glottis. And really what that's doing is auto-peeping to kind of maintain this functional residual capacity. When I was a resident, I was often associate PEEP with oxygenation, but really, especially in children, generating an auto-PEEP is trying to overcome their closing capacity, and it's because you're having atelectasis and poor lung compliance. So that could manifest as hypoxia or desaturation, but it could manifest as work of breathing or hypercarbia or poor ventilation. So grunting is not necessarily a sign of auto-peeping in response to hypoxia, but that you are not operating on your normal compliance curve and you're trying to overcome that physiologically. There are a lot of ways to kind of overcome this. So some of the non-invasive ways that we're going to talk about, and then we'll talk a little bit more about invasive mechanical ventilation. So one of the go-to methods is high-flow nasal cannula. So what high-flow nasal cannula works is kind of making the respiratory system work more efficiently. Oxygenation through low-flow nasal cannula is limited by entrained air, especially in patients that are tachypnic and taking large tidal volumes to try to maintain their oxygenation and ventilation. You're entraining atmospheric air, and so you're not getting adequate oxygen delivery. So you have to both overcome a patient's tidal volumes, but also their dead space in order to adequately saturate the non-gas exchanging airways with adequate oxygen. If you're delivering these flows at high flow rates, can also cause dryness and irritation. And so this air is humidified and warmed, but really primarily works through dead space washout. So where there's CO2 that's kind of sitting in these children's nasopharynx or in their conducting airways, you're pretty much washing all of that out with high FiO2 air and allowing them to breathe a little bit more efficiently, oxygenate better. And that's, if you've ever started a child on high flow nasal cannula, we usually start at 2 cc's per kilo. That number comes from the normal dead space of a child. So 2 cc's per kilo is usually the starting dose, and you can titrate up to 3 cc's per kilo. There's probably some PEEP that's delivered from high flow as well, but it's hard to measure both pressure and flow at the same time. So it's a little hard to know exactly how much PEEP you're delivering, but it's probably some PEEP, not quite that to the level of CPAP, but some increased positive pressure that's kind of helping maintain FRC. 3 cc's per kilo probably gets you closer to the PEEP effects of similar to CPAP, which also has some of the effects of high flow nasal cannula. Non-invasive positive pressure ventilation is one of the mainstays in bronchiolitis, pneumonia, or other respiratory illnesses in children. This is the happiest child I've ever seen on CPAP. They never look like this. PEEP is the name of the game. You're working to maintain FRC, to overcome a patient's closing capacity, to optimize their compliance as much as possible. Typically, we start at 5 centimeters of water and can titrate up as needed. Usually, you can go up to 7 in terms of CPAP, but truly, you can go up as high as you need in terms of CPAP support. Usually, we'll consider BiPAP once you've reached a CPAP PEEP of about 7. But even PEEPs of 10 or 12, if that's what's needed to maintain their functional residual capacity, that is okay. But usually, BiPAP is kind of the next step, which adds a driving pressure in addition to baseline PEEP for added pressure support. Often 10/5 is where we would start, and 16/8 is kind of usually the point where you're talking about, you're maxing out your non-invasive ventilation and kind of talking about invasive mechanical ventilation. Really, I think one thing to highlight, especially with these like giraffe devices, is the importance of a seal, especially in children that have a lot of mucus plugging and secretions. It's hard to kind of suction those, so you have to kind of remove the entire system in order to get a good suction. And these can occlude. And so there are times that the giraffe device can cause suction events that impair ventilation and can actually lead to desaturations. And so it's just a real exercise in working with your respiratory therapist and all the different team members to find an appropriate seal and interface that works for a child. And especially as children grow, it sometimes can be between interfaces. And so it can be a little bit of kind of work to find the right setup that works. If you find a setup that works, though, non-invasive positive pressure is usually very effective and usually can avoid intubation in a lot of cases. In cases of like bronchiolitis, for instance, these patients are often tachypnic, have retractions, work of breathing. But with positive pressure, are ventilating and oxygenating appropriately and kind of can ward off the invasive mechanical ventilation. Usually the patients that require being intubated are patients that have something else, like a superimposed pneumonia, chronic lung disease, history of prematurity, or other kind of conditions that, further complicate a case of bronchiolitis. Then you have your ARDS, your pneumonias, things like that might have more of a hypoxia presentation, and you might need more positive pressure to kind of increase your PaO2. And that's when we start getting into the realm of mechanical ventilation. That's really in terms of indications for intubation. So hypoxia, hypercarbia, neuroprotection, low GCSS, and then my personal favorite, cardiac output support. Similar to the same indications for adults. But really want to focus most of the talk on invasive mechanical ventilation. In terms of some of the general principles, intubating is owning a patient's respiratory status, and that's a real responsibility when you're doing that. You're saying that by intubating this child, you can maintain their respiratory status, oxygenate and ventilate better than they can. That is something that takes a lot of time. It's an iterative process. It's dynamic. It kind of changes. And over the course of a respiratory illness, it can change as well. There is no perfect ventilator mode. We're going to talk about a couple of different ventilator settings, and there maybe are some physiologic bases for one over another in certain situations, but nothing is perfect. And really, it comes down to inputs and outputs and making sure you're taking the right information in and receiving the right information out to make the best decision about how to better ventilate and oxygenate somebody. The main goal is to provide adequate support for the minimum amount of time and minimizing lung injury, which is easier said than done. But it again kind of means that we have to watch these settings closely and kind of adjust, which makes it challenging in an emergency department where you have, many patients, you have don't always have the time to be able to titrate these things. But I'm hoping to talk about a couple of different quick situations that you might be able to troubleshoot while organizing and mobilizing to getting them to an intensive care unit where there's a little bit more time and resources to be able to kind of make those titrations and to make those changes. So in terms of components of a ventilatory mode, every ventilator and every ventilator setting has a couple of key features. So they all have a trigger. That's what initiates a patient breath. They all have a cycle, and that's the duration of how long a breath is. When does the breath stop after it's triggered? They all have a limit. So some number that you're kind of waiting to reach in order to reach the duration of that breath. And then a baseline, which is usually just the PEEP that exists between ventilator breaths. The trigger can be multiple things. It can be time. If a patient hasn't taken a spontaneous breath on their own, the ventilator will say, okay, now it's time to take a breath. It can be from a negative inspiratory pressure because the patient is ready to take a breath. Their diaphragm contracts. That negative pressure tells the ventilator, okay, I need to give a breath. This patient's trying to breathe. Usually probably the one that's the most common that we see in pediatrics is flow, especially in small children. Generating a negative pressure to trigger ventilators is challenging because they aren't able to kind of sense the negative pressure. But flow is something that's a little bit easier for the ventilators to detect. So that's usually the trigger that most pediatric ventilators use. Cycle is usually time. We talk about like I times, inspiratory times. That's usually the duration of a pressure-controlled breath. But there are pressure-supported breaths that operate on flow mechanics, and it's a little bit complicated out of the scope of this talk, but that's one of the other ways that ventilators work in terms of cycle. The limit is probably the factor that we talk the most about. So there can be pressure-controlled ventilatory modes or volume-controlled ventilatory modes. And pressure control is just that. You're delivering a set pressure, and then your output that you're watching is a volume, and volume control is you're setting a set volume, and you're watching what the generated pressure is needed to achieve that volume. And then the baseline, as we kind of mentioned, is PEEP between ventilatory breaths. I had a slide here on assist control, which I think is primarily one of the ventilatory modes used in adults. I've never seen it done in children. We always do synchronized intermittent mandatory ventilation. And within that, there's a lot of different kind of subsettings: SIMV, pressure control, volume control, and PRVC, which are the three main kind of ventilatory modes that I'm going to talk about. This is a combination mode that delivers both controlled breaths that are either volume controlled or pressure controlled, and supported breaths. So they offer a pressure support. Why is that different, or what are the advantages of that as opposed to assist control? Assist control, every single patient triggered breath gives a full controlled support from the ventilator, whereas pressure supported SIMV gives you the opportunity to breathe above the ventilator, which is especially useful in children that are often tachypnic and have respiratory rates that are much higher than adults. It also allows you to wean ventilator support, so you can come down on the controlled breath and really utilize pressure support. It's really useful when we're trying to wean somebody off of a ventilator. Maybe not as relevant when you're first starting, especially in somebody who's sedated, paralyzed, and you're doing primarily most of the work. But it offers that mix and gives you a little bit of flexibility. In terms of the trigger, it's usually flow, but of course, if a patient's paralyzed, they're not going to generate a negative flow to kind of trigger a breath. And so after a certain set time, depending on the respiratory rate that you've set, the ventilator will kind of kick in. Cycle tends to be time, and usually I time is the feature that you would kind of titrate. We talked about the pressure or volume controlled breaths, and then PEEP kind of as needed. This is a pressure controlled ventilator mode. So you can see there's 3 scalar forms that you'd see on a ventilator. So there's pressure, flow, and volume, and they always kind of exist in those 3 in that kind of iteration. So you can see this is a pressure controlled mode for 2 reasons. One, the pressure, you have a set pressure that's in the top waveform. And the top waveform, you see that square yellow wave. You're delivering a pressure for a set entire inspiratory time. And then once that time has been met, you no longer deliver the pressure. What that does on the bottom waveform, it gives you kind of a shark fin pattern of your volume. And so your volume slowly goes up. And then as you don't deliver that pressure anymore, your volume slowly comes down. One of the features that differentiates pressure control and volume control and gives you some kind of advantages of one versus the other is the flow pattern. You can see that the flow pattern has this kind of decelerating curve. And so there's kind of 2 features to the flow. There's both inspiratory and an expiratory phase. So while the pressure is delivered at a set I time, you have a big spike in your flow as you're having an inspiratory pressure flow in. Then it decelerates as the pressure kind of equilibrates within the respiratory system. That more closely mimics how our own kind of respiratory mechanics work. And so that pattern tends to be a little bit more comfortable for patients, and it can be a little bit better in terms of ventilator synchrony. Now, this has a little bit of extra information that we're going to talk about, but you can see that the flow pattern, I'll start there, is a square pattern. The volume tends to look similar, but it's a little bit more square-like because you're kind of reaching to a set volume and then decelerating from there. And the peak pressure, the pressure waveform is less square and more kind of has that slope up as you're kind of generating that pressure to kind of achieve that volume. One of the things that's unique to volume control ventilation is because the flow is this kind of square pattern, the change in pressure, which is what you're kind of measuring in a volume control mode, is a function of both the alveolar pressure and your compliance of the alveoli, but also the airflow that's going through the system. In a patient where you're delivering constant flow, you're not going to really be able to adequately see what the pressure is at the alveolar level. And so something that we will do, and it's somebody with a volume control mode, is take the inspiratory flow out of the equation. And you would do that with an inspiratory hold. And that allows you to get a plateau pressure. If there's any airway resistance contributing to your high pressure from mucus plugging, a kinked ET tube, bronchospasm, or asthma, you'll see that when you do an inspiratory hold and you take airflow out of the equation, your peak pressure will drop. And you might see, even in patients without a lot of mucus secretions or bronchospasm, you'll probably see a little bit of a drop in your plateau pressure as opposed to your peak pressure. And that plateau pressure is what the pressure that's actually being transmitted down to the alveoli. You don't have that same issue in pressure controlled breaths because you have that decelerating flow curve. And so you reach a point where you're at 0. So at the end of your pressure waveform, that is the pressure that's being transmitted to your alveoli. And so that gives you kind of a sense of what the alveolar kind of compliance is. So in terms of pressure control versus volume control, some of the benefits of pressure control is you have that decelerating flow curve. It's a little bit more comfortable. You also get a little bit more of an even distribution of ventilation to different alveolar time constants and different alveolar units that have different compliances, especially in lung disease that can be heterogeneous. Some alveoli are more compliant, some are less, some have more resistance, some have less. and giving that decelerating pattern, make sure that the air is more evenly distributed across all of them. Because you're setting a set pressure, presumably you're setting at a lower pressure, and so you're limiting barotrauma. And because it's kind of evenly distributes ventilation across different units, it's a little bit more ideal for sick lungs or patients with an acute illness. Whereas volume control has a different flow curve, as we kind of mentioned, gives a set volume, and you can almost self-wean if somebody's in a volume control mode, because you'll watch the peak pressures that are needed to generate that volume. And over time, as their compliance improves, the pressure will come down and down until you reach kind of an extubatable peak pressure. That limits volutrauma because you're setting a set volume, but you can have barotrauma because you might require a high pressure to kind of generate that volume. And this is just another kind of picture that illustrates that, have different alveolar units that have different compliances, different resistances. And with a pressure controlled mode, you're a little bit more evenly distributing that across different alveolar units, where a volume control mode, you might be hitting just the good alveoli with a large amount of volume, and you're actually not aerating sick lung, you're just damaging healthy lung, which really the main goal in these patients, especially in like ARDS or different illnesses, is that you want to preserve as much healthy lung as you can, ventilate what you're able to in terms of the sick alveolar units, but not cause additional damage. Again, I've talked a lot about different waveforms, but how does this actually look at the bedside? You're going to get called to a patient's room, their ventilator. What does it actually look like? This is the Servo I. This is the ventilator that we use at Columbia. I'm not actually sure what the ventilators that you guys usually use here, but this is kind of typical settings that you would see for a patient in a particular mode. Does anybody want to say what mode this is based off of some of the waveforms? I think I heard somebody say it. Pressure. So it's pressure because you've got a square pressure waveform at the top. You have that decelerating flow curve. And you can also see that at the settings that you've set at the bottom, you're not setting a set tidal volume, you're setting a PEEP and a pressure control above PEEP. So this is a pressure control mode. So this is SIMV pressure control with pressure support. You can see these little, in the flow waveform, you can also see these little pink portions at the beginning of each breath. And that's telling you that's a patient triggered breath. So either pressure support or triggered pressure control breath, which can be useful if somebody's waking up after being sedated or wearing off in terms of their paralytic. They're triggering the vent. It kind of tells you that they're taking their own spontaneous breaths and generating enough of a diaphragm pressure or flow to tell the ventilator that they want more support. This is a different ventilator mode. We kind of talked about pressure control. So, this is probably not a secret. This is volume control. You have a more square waveform in terms of your flow scalar. You have a little bit more of kind of like a shark fin of your pressure. You can see here, there's actually like a couple of different waveforms. The first two are a little bit more square, and then your third one is a little bit more kind of decelerating. That's a pressure supported breath. And so you can see that, the volume curves look a little bit different. The pressure curves look a little bit different. But you can see that at the bottom, you're setting a set tidal volume. You're still setting your PEEP and your rate. Also, just to kind of orient those are the inputs that you're setting. So you're setting that tidal volume in the bottom, but what you're looking at is your peak pressure in the top right. For a tidal volume of 500, which would be a normal one for adult, obviously a very large volume for a child, you're requiring a peak pressure of 28 in order to generate that volume. That can be a factor of your lung compliance. It can also be a factor of your PEEP. If you're starting at a PEEP of 8 and you're generating an additional 20 centimeters of water to achieve that volume of 500, there are multiple factors at play. Going back to pressure control mode, you can see that your outputs, your peak pressure is set. It's 14 plus 8. It's going to be what you kind of set on the ventilator. But what changes is your volumes. So the bottom right, you can see VTI and VTE. VTE tends to be the number that we use in terms of your expiratory volumes, and especially in children where they can have a larger proportion of leak around the ET tube. That tends to be the one that's a little bit more accurate in terms of what the volumes that your actual alveoli are seeing. So usually you would set a peak pressure or delta pressure or driving pressure on top of PEEP, and you'd be watching your expiratory volumes to see if they're appropriate for age. These are a couple of the maneuvers that we kind of talked about. So in a volume control mode, if you there's a button that doesn't show up here, but separate on the ventilator for an inspiratory hold. That allows you to kind of take airflow out of the equation and generate what the pressure is that's being seen by the actual alveoli. If you click additional settings, additional values here on the ventilator mode, you can get this screen and you would see a plateau pressure that's generating. So if you had a peak pressure of 41, you did an inspiratory hold and your plateau pressure goes down to 25, you can say that there's some degree of airway resistance, whether that's bronchospasm, mucus plugging, something that is leading to that high peak pressure, but not an issue with lung compliance per se. And you can have both. You can have an elevated plateau pressure and a higher peak pressure because you have both airway resistance and poor lung compliance. Another maneuver you can do on the ventilator is an expiratory hold. In patients who have air trapping or bronchospasm, doing an expiratory hold tells you the PEEP generated by patient's own airway volumes is generated. It might be higher than the PEEP that you've set on the ventilator. So in this patient, they did an expiratory hold, and you can see that the auto PEEP is 16. That's what's actually being measured at the level of the alveoli when the PEEP is 12. That can be because there's air trapping or not having adequate time to exhale. And you can see on the flow curve, you have the inspiratory phase and the expiratory phase. You always want the expiratory phase to reach back to the baseline. If it's not reaching back to the baseline, you're not having a full exhale, and there's going to be some proportion of that breath that's sitting in the alveoli. And over time, you can have breath stacking and develop auto PEEPing. But this is a way that you can see on the ventilator if there is some degree of auto PEEP. Pressure regulated volume control, or PRVC. This is kind of a combination of both pressure control and volume control. I think that some people kind of think it's the best of both worlds. You are setting a tidal volume. The ventilator takes a couple of breaths to see what pressure is needed to generate that tidal volume. And then we'll use that pressure in a pressure controlled mode for the next couple of breaths unless the compliance kind of changes. And it reassesses it every few breaths and adjusts the pressure that's needed if the compliance improves or worsens. I say the best of both worlds a little bit facetiously because there is no perfect ventilator mode. And so there are drawbacks, which we'll talk about. But this does give you a set tidal volume, so you kind of limit volume trauma, but you also set a peak pressure that the ventilator won't go above. And so you can set a limit so you don't reach injurious peak pressures as well. You do that by setting an alarm pressure that the ventilator won't deliver over. So typically in terms of plateau pressures that we don't want more than 30 centimeters of water, you might set an alarm on PRVC for, say, 40. That means that the way it's kind of set up is that once the ventilator hits a pressure of 35, it will cut out the breath and won't deliver any extra pressure beyond that. And whatever tidal volume you get is what you get. You can see that would be advantageous in preventing lung injury, but there are times that patients have very poor lung compliance and they need that extra pressure and you're not adequately kind of ventilating them. If you have a prolonged period where you're having cutting out of the breaths, these patients can develop worsening acidosis fairly quickly if they're not getting the adequate support. But you'll get a lot of alarms if you're in this mode and you're hitting that set point. This is PRVC. And so you can see that it's PRVC because you're setting a tidal volume and you're still getting that decelerating flow curve. So the ventilator sees that you want 500 cc's of tidal volume. It's taking a couple of breaths to see what pressure is needed to generate that tidal volume. So it's seeing that a peak pressure of 30 is needed to get 500 cc's of volume when you have a PEEP of 8. So a driving pressure of 22. And then it's going to deliver peak pressures of 30 indefinitely as long as you're achieving that tidal volume. You can see here the expiratory volumes are 442. So it might think, I need to generate a higher pressure. You can see on this monitor, the regulation pressure is limited. Eventually, it's going to reach a point where it's going to cut out alarm and not generate a pressure beyond that point. So, there's added advantages to this, but there are also disadvantages, especially in patients with poor lung compliance. You can also imagine a situation where somebody has a lot of vent dysynchrony and their, the breaths that they are wanting in terms of air hunger are different from breath to breath. And you can imagine that would be a little bit challenging for a ventilator to keep up with. And so it can sometimes exacerbate vent dysynchrony if a patient is having trouble kind of getting the adequate tidal volumes that they need with each breath. At the end of the day, this is inputs and outputs. We have goals in terms of mechanical ventilation that we're trying to maintain. We have settings that we can put in the ventilator and then outputs to make sure that we're meeting those goals. Some general goals: we want to minimize FiO2 as much as possible. Using PEEP and other strategies and delivering adequate pressure and improving lung compliance will allow you to wean FiO2 from a non-invasive support. If you're able to achieve FiO2, usually less than 40%, that's obviously ideal, but that's dependent on the underlying disease process and where the patient is in their course. Adequate tidal volumes for age. So we usually use 6 to 8 cc's per kilo as a general ballpark of tidal volumes. Sometimes it can be a little bit more, sometimes it can be a little bit less. In my experience, especially with premature babies, they tend to need higher tidal volumes. So it's not uncommon that they'll reach 10 cc's per kilo of tidal volumes. A lot of information that we've learned from the adult side is that minimizing tidal volumes in the setting of lung injury and trying to target a less injurious tidal volume goal in the setting of pediatric ARDS is usually kind of our target. Then minimizing plateau pressures, so less than 30 centimeters of water. Or if you're in a pressure controlled mode where you can't use a plateau pressure, a peak pressure that's less than 30. So just kind of, if depending on what mode you're in, some of the ways to kind of think about how to titrate a ventilator: what are the inputs, what are the outputs? So in a pressure control mode, you're adjusting pressure to achieve a goal tidal volume, a goal pH, and a goal PaCO2. If you're not meeting those goals, you have to think about why. Is there airway clearance that you're falling behind on? Does the patient need suctioning? Do they need chest saline? Something to kind of free up any kind of mucus plugging that's contributing to the problem? Do you need to adjust the driving pressure to increase the pressure that's generated to give it a higher tidal volume? But one of the things that's also really important to keep in mind is adjusting the PEEP and the I time. If you're on this lower part of the curve and you're using a lot of your driving pressure in order to just open up the alveoli to begin with, like go from atelectasis to an open alveoli, that's a lot of wasted pressure. If you start with a higher PEEP, you might already have alveoli that are open and are more compliant and better able to accommodate more pressure, and you might get more bang for your buck, for lack of a better term. So you're adjusting your driving pressure and your other settings, and in real time, you can watch your tidal volumes, how they get adjusted and change, your minute ventilation, which is a function of your tidal volume and your respiratory rate, your end tidal CO2, your arterial venous blood gases, all the different parameters, and you're titrating those to achieve those goals. It's really just a lot of trial and error and figuring out what combination of things work for a given patient. And sometimes that takes time. It is a little bit of trial and error and time that I know you guys don't always have, but that is the general kind of principle if you have a couple of minutes to sit at somebody's bedside. In a volume control mode, you're setting a tidal volume and you're monitoring the peak inspiratory pressures. All the same concepts apply. You're just looking at different outputs. So airway clearance, optimizing PEEP or I time or tidal volumes to minimize that peak inspiratory pressure. One thing to keep in mind that you can do in a volume control mode that you can't do so much in a pressure control mode is distinguish airway resistance from changes in lung compliance. And we talked about doing an inspiratory hold to measure a plateau pressure. Give some example cases that I was hoping we can kind of go through. So we're going to have a couple of cases, and I think what I was going to do is split you guys into thirds. We'll have a case. If this group could just kind of talk about the ventilator mode, this group talk about what is going wrong, and this group over here can talk about how we're going to fix it. All right. So first case, this is a 6-year-old with persistent asthma who's here with status asthmaticus that's refractory to non-invasive measures and required intubation. They had a gas that shows a worsening respiratory acidosis with a CO2 of 58. They have a little bit of hypoxia with a PO2 of 71 and a SAT of 91, and an tidal of 50. Their weight is 20 kilos. This is their ventilator. This group could tell us what ventilator mode we're in. This group could tell us what the problem is, and this group could tell us how best to fix it. So this patient has some respiratory acidosis and hypoxia. Looking at some of the settings and given their kind of underlying pathology, what are some of the things that maybe jump out to you as abnormal or maybe not working for this patient? Yeah, it's cut off a little bit, so it's a little hard to tell, but I agree. I think that the baseline is not fully coming back to zero in your flow pattern. So what could you do on a ventilator to kind of sort out if there is some degree of breath stacking? You've come down on the respiratory rate. They're breathing at 28, so they have some degree of air hunger, and you're sat at 24, which is a pretty high respiratory rate in somebody who's asthma needs adequate expiratory time in order to exhale off their CO2, just maybe contributing some to their respiratory acidosis. You could also do an expiratory hold, which would allow you to measure if there is some degree of auto peeping. And that might kind of tell you that your PEEP, if you do an expiratory hold and your PEEP is say 10, maybe you need to adjust your PEEP some and come down on that setting as well. Those are some of the kind of changes you could do. Do you have time for one more? Or one last one? Okay. All right. This is an 8-month-old who's in the ED with multifocal pneumonia. It's refractory hypoxia. They're intubated for hypoxemic respiratory failure, mechanically ventilated in volume control. And the respiratory therapist is coming to say that you have peak pressures that are reading higher than 30. This is their gas. It's a little bit acidotic, but not terrible. But their SATs are low. It's 89%. Their end tidal is 43. Their weight's 6 kilos. This is their ventilator. Maybe if anybody could just shout out if there's something that they see that could be adjusted or changed or thoughts that they have. And for the sake of time, I'll tell you this is a SIMV volume control mode with pressure support. So what's abnormal in this tracing in terms of the outputs that we're looking at? Peak pressures are high. They're reading 36, which this is a peak pressure, not a plateau pressure. We did an inspiratory hold. We might see if this is an airway resistance problem because of mucus plugging or airway clearance, or if it's a compliance problem. I think we have some other evidence that maybe it's a compliance problem, that we're desaturated and on a high FiO2 and having signs of evolving ARDS. If we have compliance issues, what are some other things we can maybe assess or change on the ventilator that might help with our overall compliance and kind of bring us back to functional residual capacity? What's that? Yeah, so we're only at a PEEP of 5, and so maybe your peak pressures are high, so it's a little bit counterintuitive to increase your pressure to try to decrease the output that you're looking at, but maybe giving a PEEP of 7 or a PEEP of 8 or even higher than that might recruit more alveoli, use your pressure more efficiently, lower your FiO2, and actually lower your peak pressures. One other thing just to point out is that this tidal volume is set for 60 cc's. This is a 6 kilo child, I think. So maybe you're also generating high peak pressures because the ventilator is set at a supraphysiologic tidal volume. So other things to kind of consider: are you adequately supporting this patient, or are you maybe doing too much support and kind of bordering to injurious territory? That's all I have. Thank you, guys.